Welcome, and thank you for joining us today for the program. This is our webinar series called Sight and Sound Bites. It's brought to you by the Eye and Ear Foundation. My name is Craig Smith, and I'm a development officer with the foundation. This bi-weekly webinar series highlights research in the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh School of Medicine. This research is only possible thanks to generous philanthropic support, so thank you to all who have supported our mission over the years. I want to go over a few housekeeping things for today. For these webinars, we do disable the chat function. However, you can submit questions for the presenters through the Q&A feature at the bottom of Zoom. After the presentation, we will answer those questions for you. We do ask that you refrain from asking extremely personal questions that may not be relevant to the broader audience. However, we'll try to answer those questions offline and get back to you after the program. As always, you can send additional questions to me through my email, which is just craig@eyeandear.org. We've also enabled captioning for this program, so please feel free to use subtitles as you follow along. And we'll also be recording this webinar and adding it to our website. So if you're not able to view it all or would like to view it later or share it with others, you'll be able to find it on our website next week, which is just www.eyeandear.org. Additionally, all of you who are attending today, we will be adding you to our mailing list so you can receive periodic updates on various research taking place within the departments, including blogs, newsletters, and invitations to future webinars that we'll be holding. Today's presentation is titled Hereditary Hearing Loss, New Innovations for Treatment. We are happy to be joined by three of our esteemed faculty members. We have Dr. Jonas Johnson, Chairman Emeritus of the Department of Otolaryngology. And our two speakers today are Dr. David Chi, Associate Professor of Otolaryngology and the Director of the Division of Pediatric Otolaryngology at UPMC Children's Hospital, and Dr. Christopher Cunningham, who's an Assistant Professor of Otolaryngology. I'll now turn it over to Dr. Johnson to introduce today's speakers. Dr. Johnson.
So thank you, Craig. I'm delighted to be with you all today with my two esteemed partners. Thousands of children are born with profound hearing loss. And the good news that's evolved over the last couple of decades is these children can be treated with cochlear implantation. The better news, I think, is that modern science is beginning to offer perspective on the potential that something more that could be done. So with that, I want to introduce you to Dr. David Chi, who's the Director of Pediatric Otolaryngology at the Children's Hospital of Pittsburgh, and to Christopher Cunningham, who's a neuroscientist who works with our department here at the University of Pittsburgh. And they are going to walk you through what might be really new innovations for the future. So, gentlemen.
So thank you, Jonas, and thank you to the foundation for giving us the opportunity to present. We're excited to share our presentation, which is the Hereditary Hearing Loss, New Innovations for Treatment. The outline of our presentation first is from the clinical side to talk about the significance of hearing loss and the causes of hearing loss, and then let the exciting talk from Dr. Cunningham talk about some of the cutting edge technology and cutting edge development for the treatment of hearing loss. So to start off, let's pretend that we are sound, and this is how normal hearing occurs. We're traveling in the ear and go through the ear canal, and we as sound cause the eardrum to vibrate and move. When this movement occurs, there are three bones in the middle ear that also move: the hammer bone, the anvil bone, and the stirrup bone. When that occurs, it causes us to have the fluid shift in the inner ear. This fluid shift causes the displacement of these hair cells. There's one row of inner hair cells and three rows of outer hair cells. The movement of these hair cells then create release of neurotransmitters, and this neurotransmitter release then causes electrical signals to traverse through the hearing nerve to the brain, and we perceive that as sound. Here is a magnified view of these hair cells on the left. And on the right are some additional magnified views of the one row of inner hair cells and three rows of outer hair cells. When there is damage to these hair cells, that is the thought that is the cause for hearing loss for children as well as in adults. Well, hearing loss is the most frequent birth condition. When we look at various common conditions that are in the public, we talk about cleft lip or palate, Down syndrome, limb defects, but hearing loss occurs in approximately 3 per 1,000 live births. This is equivalent to about 12,000 infants born annually in the United States, or 35 babies per day who have significant hearing loss. Well, why is this so important? Well, we view that once there is a hearing loss that's identified, that it is a neurodevelopmental emergency because early intervention has significant benefits. Various studies have shown that if you intervene for the hearing loss, there are better speech and language scores for these children. That is why we in the state of Pennsylvania and almost all other states have the universal newborn hearing screen. There is a statement of 136. That is the goal. We want to screen by 1 month of age. We want to have an audiological diagnosis by 3 months of age and early intervention by 6 months. The Joint Commission of Infant Hearing actually has established new guidelines, and now the push is to have 1, 2, 3. We want to screen by 1 month of age. We want to have the diagnosis by 2 months, and then have the intervention by 3 months of age. So people ask, what causes hearing loss in children? Well, when we break down the causes of hearing loss, about 25% of the time it's thought to be an acquired cause. About 25% of the time when we look for the causes, we don't identify a cause. And about 50% of the time is thought to be genetic. When we look at the genetic causes, about a third of these are syndromic. And there are more than 500 syndromes that have been identified that have been associated with hearing loss. Our goal is not to go through all 500 syndromes, but to highlight that actually the majority of the cases are non-syndromic. That is, that there are no other conditions except for the hearing loss. And when we break down the different inheritance patterns, the most common is an autosomal recessive, about 60 to 80%, and autosomal dominant, 15 to 20%. There are less common causes of inheritance, such as X-linked and mitochondrial. We'll talk about the autosomal recessive and dominant causes. First, for the dominant. By definition, it means that one parent usually has hearing loss, and the parents have 50% risk of transmitting the gene for hearing loss to their child, and 50% of their children will have the hearing loss. Autosomal recessive is the more common cause, and each parent has the gene. They themselves usually do not have the hearing loss, but they are the carriers. Because each parent has a gene and they only pass one gene to their child, there's a 25% chance that the offspring of these parents will be affected. The most common cause of autosomal recessive hearing loss is connexin 26. It is DFMB1, which is mapped to chromosome 13. And this is a mutation of the gene GJB2. And this mutation, this single mutation, is associated with 50% of autosomal recessive hearing loss. And the care rate in the Midwest United States is 2 to 3%. That means that if there are 500 people who are listening to this Zoom conference, 2 or 3 of us may actually carry this gene for the connexin 26. So what is connexin? Well, probably the best way to view it is that connexin are docking stations for cells to communicate with each other. They are proteins within the cell membrane that allow these connexin proteins to link with another cell, and they're all throughout the inner ear. Mutations in this gene leads to cellular dysfunction and deafness. There are also acquired hearing losses. About 25% of the time is thought to be acquired, and a couple of these deserve mention. First is infections and prematurity. Prematurity is the most significant perinatal factor. There's a 20-fold increase in hearing loss if a child is premature, and 5% of NICU graduates will have hearing loss. The other main cause of acquired hearing loss that deserve mention is CMV, or cytomegalovirus. We've all become familiar with viruses the past 2 years, and this is another dreaded virus that starts with C. It's in the herpes virus family, and over $4 billion per year are spent in medical expenditure to treat conditions associated with CMV. 0.5 to 1% of all newborns will have this, and 30,000 congenital CMV infections occur. This is the most common cause of a non-hereditary sensorineural hearing loss, and 20 to 25% of early childhood hearing loss is thought to be associated with CMV alone. CMV can occur in symptomatic or asymptomatic fashion. The symptomatic means that there are other conditions associated with CMV, and this occurs in approximately 5 to 10%. For otolaryngologists, the main point is that about 50% of symptomatic CMV infections are associated with sensorineural hearing loss. This is a picture of one of our children that we have taken care of with bilateral profound hearing loss and microcephaly, and subsequently requiring cochlear implants. The more common is the asymptomatic congenital CMV infections. That is, there are no other associated features with this infection. The main point is that 5 to 50% of asymptomatic congenital CMV infections also have sensorineural hearing loss, and the hearing loss can be evident at birth or later in childhood. There is unfortunately no predictable method to know which children will get hearing loss associated with CMV. So what are the therapies for children with hearing loss? Well, it depends on the degree of hearing loss, and hearing loss may range from mild to profound. Hearing aids are the primary option when there is lesser degrees of hearing loss, but then once we get to the threshold of severe to profound loss, children and adults may not benefit from hearing aids alone, and cochlear implants are indicated. Hearing aids amplify sounds. Cochlear implants work differently because they actually bypasses the hair cells and actually stimulate the nerve endings in the inner ear. And those who are not benefiting with hearing aids alone may then become a cochlear implant candidate. This is where it leads and transitions to the cutting edge research that Dr. Cunningham is doing. As otolaryngologists, the current state is that we treat the sequela of hearing loss. We offer hearing aids. We offer cochlear implants. But the work of Dr. Cunningham is to treat the underlying cause of hearing loss. And I'm excited to pass the microphone over to him to share the next part of the presentation.
Thanks a lot, Dr. Chi. I'm honored to give this talk after you. Dr. Chi is really a rock star in science in the Pittsburgh area, treating children with hearing loss. And I feel really fortunate to be a colleague of his and to learn from him. And today I'm going to share a little bit of my work, and hopefully in the future, people like Dr. Chi will be able to utilize some of the things that we've found. So before I talk about my work, I want to talk about the people in my lab who actually do all the work. We started our lab here a year ago, and in this time, we built our lab up to 8 people, and I would say 8 phenomenal people who are excited and curious and driven to make positive change in science and medicine. So these are the people, and I'm going to show you some of their work today. So thank you to them. Also, thank you to Dr. Thanos Susanopoulos, who heads the Pittsburgh Hearing Research Center, Diana Martinez and Brandon Bizup, who helped getting our lab off the ground. And then my previous postdoctoral mentor at Johns Hopkins, Ulrich Mueller. And then, of course, we couldn't do what we do without our funding sources, one of which is the Eye and Ear Foundation. And I'm actually going to talk about work today that has been funded by the Eye and Ear Foundation. So Dr. Chi did a really great job introducing this point. So I'm not going to belabor the point, except to just add to the emphasis that hearing loss is the most common sensory deficit. 1 in 8 people in the US over the age of 12 has hearing loss, and something like 6% of the world's population has disabling hearing loss, and that number is projected to rise. Dr. Chi showed a really cool video of sound going into the outer ear, through the middle ear, and into the cochlea. I'm gonna make my pointer visible real quick, which is this structure right here. So this is the inner ear, and the cochlea is the snail-shaped structure. And the most common cause of sensory neural hearing loss is dysfunction of those hair cells, like he talked about in the cochlea. And I'm going to talk a little bit about that today. I should add that also in the inner ear is another set of structures called the vestibule, which is really important for balance and head position and things. So if you unwind the snail-shaped structure of the cochlea, it's like a fluid-filled tube that looks like this. And then if you take a cross-section through that, you can see the hair cells that Dr. Chi was talking about. 1 row of inner hair cells and 3 rows of outer hair cells. And the reason they're called hair cells is because they have these like hair-like projections at the top called stereocilia. Those things move in response to sound. And in that way, the hair cells in the cochlea are actually the mechanical sensors of the auditory system. They take a mechanical sound wave, respond to the force, and then convert it into a neural signal that is routed to the brain. So when you look at a hair cell in cross-section, what you can appreciate is that there are all these really unique protein-based specializations that are critical for auditory processing. And one of these that I will highlight today is this right here, which is called the mechanoelectrical transduction channel, which is a mouthful, the MET channel. The MET channel is actually the channel that directly converts the sound wave into an electrical signal that's sent to the brain. And oftentimes with hearing loss, you have improper localization of these critical proteins. So if you'll notice, these channels are precisely located at the tips of these hair-like projections called stereocilia here. This localization is critical for their function. If a mutation occurs, oftentimes they will not localize properly anymore, and they won't be able to function. So when we think about proteins, proteins essentially are the workhorses of the cell. They're the structural support. They do all the enzymatic activity. Essentially anything you can think of almost that is occurring at a cellular level is catalyzed by proteins. And DNA in the nucleus provides the instructions to make proteins. So when you think about a mutation in DNA, which is essentially the wrong DNA nucleotide in the DNA strand or gene, this leads to misfunction and misfolded proteins, which leads to hearing loss. And like Dr. Chi talked about, there are many, many different gene mutations, in fact, hundreds of gene mutations that cause hearing loss, and the genes encode for all sorts of proteins. So there's more than 100 distinct non-syndromic hearing loss genes, and there are over 700 different syndromic forms that are associated with hearing loss. So there's lots and lots of ways that you can mess up the system and get to hearing loss. Really, as a researcher, I want to understand the system better, and I want to develop therapies that can potentially help improve the system for people with mutations or other forms of hearing loss. And so we use the mouse as a model for studying genetic hearing loss. This is a schematic of the cochlea. And if you take a cross section through the cochlea of a human, it looks like this. So the tube kind of spirals around this bone in the middle called the medialis. If you take a similar cross section through a mouse cochlea, it looks like this. So the anatomy of the mouse and the human cochlea are very, very similar. They have the same proteins, they perceive sound the same way. And importantly for genetic hearing loss, nearly all of the genes that are critical for non-syndromic forms of hearing loss in humans have been studied in mouse models, and most hearing loss in both mice and humans are the same in onset, the same in severity, the same in pattern, and the same in progression. So we have a really powerful model that we can use in the mouse to study things that have direct implications for human hearing function. And really, my goal as a researcher is to use deafness-linked genes in mouse models to better understand how does the auditory system in the cochlea work, and potentially to develop novel therapeutic targets. So how do we do this? Well, first we use what's called mouse genetics to generate the same DNA mutations in mice as we do in humans. Then we test their hearing using something called the auditory brainstem response, which is also used in hearing to test, or in humans to test hearing and other tests. We verify that the mice have hearing loss. Then we look inside the cochlea to look at the structure of the cochlea, the molecules, the cells, to see perhaps what is going wrong in the cochlea of these mutant mice. And we use biochemistry and molecular biology to test how specific DNA deafness-linked mutations affect the structure and the function of genes and proteins. And you can see up here, I have a number of examples of different types of microscopic images from a mouse cochlea. This one all the way to the left is a cross section, and you can see the hair cells here. Here is a zoomed in version of the hair cells, and you can see the stereocilia in purple. And then if you go even further in with something called a scanning electron microscope, you can see the stereocilia at a very high resolution. But of course, the ultimate goal is therapeutic development. And we want to be able to generate targeted hearing loss therapies in mice. And because the mouse is such a good model for humans, we feel like there isn't a big jump for translation from what we learn in the mouse to what we can do in human patients. So I'm going to tell you a small story today about some of the research we're doing on this gene called LR-TOMT or TOMT. I'll refer to it as TOMT. And essentially, humans and mice with mutations in this gene have profound deafness. And so I told you before, we measure hearing in mice with an auditory brainstem response. And essentially how we do that is we put these little electrodes under the skin near the ear, and then we play sounds of varying intensities and pitches or frequencies to the mice. And then we record neural activity that looks like this. And it's a defined neural activity. And so we can figure out with what intensity of sound and what frequency of sound do we get particular neural activities. And this is essentially telling us how well the mouse hears. So the data summarized actually look like this. On the x-axis is something called frequency, which is essentially just pitch. So lower numbers equal lower sounds, higher numbers equal higher sounds. And then we have threshold on the y-axis. Essentially, threshold is how good can you hear. So the lower numbers are actually better, meaning people or mice with these have a threshold around 40 decibels, which means that's the level at which they can hear a sound. However, for TOMT mutant mice, you can see these are 3 different mutant strains of TOMT, and they all have thresholds at about 90 decibels. And I would say that 90 decibels is probably not the ultimate threshold, because that's just the upper level at where we test. So they're profoundly deaf. And now as a researcher, we have this mouse model. We know that they're profoundly deaf. And the question is why? And so the first thing we looked at was the hair cells. Dr. Cheese showed that really nice picture from earlier, where there was a difference between a normal patient and a patient with hair cell death and damage. So we use scanning electron microscopy in the same way in the mouse to look. And you can see in a wild type or normal mouse, the stereocilia of the hair cells look like this. And in mutant TOMT mutations, they look like this. In fact, they look very, very similar. We didn't see any hair cell death. We didn't see any major changes in the structure of the stereocilia. We didn't see changes in synapses. However, we did see a difference in localization of a critical protein. And this is that mouthful mechanotransduction MET channel. So again, from my schematic earlier, the channels typically sit at the tips of stereocilia. So if you look at this microscopic image, which is the stereocilia is stained from a mouse in magenta, and then the channel is actually stained in green. And you can see at the tips of the stereocilia is the channel protein. This is in a wild type mouse. When you look in a TOMT mutant mouse, you can see that the channel protein no longer is localized to the stereocilia. And because this channel actually converts the sound wave into the neural signal, the sound wave essentially gets stuck at this point of the auditory pathway, because the hair cell can't convert the sound wave anymore because the channel protein is no longer where it needs to be to actually respond to the sound wave. So we know so far about TOM-T that mutations cause profound deafness. We know that sound waves aren't sensed properly, and we know it's essential for MET channel localization. But the real question is, can we get the channel back to the correct location with a therapeutic strategy? And if we do that, can we actually rescue or restore hearing function? And so now I'm going to talk a little bit about our work developing gene therapies. So Dr. Chi talked about the hearing aids and the cochlear implants, which have dramatically changed people's lives, and they'll continue to. Really, really powerful therapies. And the one thing about them, though, is that they're not biological. And so they attempt to minimize or overcome secondary effects of the hearing loss. They work very, very well for some people and not so well for others. And our goal is to really directly address the primary cause of the hearing loss, in this case, DNA mutations, with gene therapy. So when you think about gene therapy, you can think about a cell here with a non-functioning gene, and it's non-functioning because it has a mutation. Like you could think about a hair cell. Our therapy will put in a functional version or a wild type copy of the gene back into the cells and allow the cell to function normally. And in fact, there are multiple biotech companies that are investing a lot in gene therapy for different forms of hearing loss. So there's over 100 different gene mutations that cause hearing loss, at least non-syndromic. And each of these groups are working on different genes. So the way we do it in my lab is we make an inner ear injection of a viral vector, an adeno-associated viral vector, something called an AAV, which contains our wild type or our normal deafness gene. We inject it into the inner ear here. And then the idea is that it gets into the cochlea, gets into the hair cells, and essentially replaces the dysfunctional copy of the gene. And this is a picture of Alicia in our lab doing some of the work. So we inject the mice, and then we wait for a period of time, and we do microscopic analysis of the cochlea and hearing test analysis to see, first, did we get our gene of interest into the hair cells? And second, did we restore hearing function at all? So I'm happy to report that we have optimized our conditions such that we can get really efficient delivery to cochlear hair cells. And so this is a picture of a cochlea. You can see the 3 rows of outer hair cells and 1 row of inner hair cells. The hair cells are stained in blue. The cells that have actually taken up the viral vector are in green. And then it's good to see that the same cells that have taken up the viral vector have started to produce TOM-T protein, which is what we want. We want functional protein to be produced from our vector. You'll notice that our delivery isn't perfect yet. We have some cells with very high levels of expression and some with apparently almost none. And we have ideas for how to address this, which we're working on now. But in the meantime, we've started to test hearing after doing these treatments in mice. And so I'm going to show you the very first data that we've obtained. This is from the first cohort of mice that we injected. It's hot off the presses. We haven't even really analyzed it much, but I was excited about it, so I wanted to share it with you. And what you can see here is another one of those ABR traces. Again, the frequency or pitch is on the x-axis, and the ABR threshold is on the y-axis. So normal untreated and normal treated mice look similar, okay? So they have thresholds between 0 to 40 decibels across the frequency range of the cochlea, suggesting that the treatment itself doesn't seem to damage the cochlea in any way. Oops. When you look at an untreated mutant mouse from the same cohort, so this is a sibling of the other mice, you can see how profoundly deaf they are. Again, our cutoff is at 90 decibels, but they probably can't even hear up to 150 decibels. We don't know. And now I'm going to show you traces from 2 individual mice with treatment. This is the first one that received gene therapy treatment, and you can see We have rescue essentially at almost every level of the cochlear frequency axis, and especially at the high frequency areas, we're approaching normal hearing function. So this is really exciting, but we're still not particularly happy with this range here. And I'll show you another mouse, which looks kind of different, right? So in this mouse, we have normal hearing in the low frequency area. And then in middle areas, it doesn't look as good, although still 60 decibels is a significant improvement. And then a good place at 24 kilohertz, and then a very not so good rescue at 32. So what does this mean? Well, we're able to restore hearing function partially, and our restoration right now is inconsistent. And we have some ideas, and we're working to address this so that we can get full hearing rescue across the entire cochlear axis. But I also wanted to share a little bit of data from the vestibular system. So this is the cochlea, this spiral shaped thing. It's connected in the inner ear to the vestibular system. Oftentimes, mice and humans with mutations in hair cell genes have balance issues. And that's because the vestibule is important for our sense of balance and our position of, in space. People with balance issues sometimes experience vertigo. So a normal mouse, if you put it in, let me see. If you put it in a cage and just let it walk around, this is like an open field test. This is what it looks like. Just walking around, kind of exploring things. Not too crazy. But if you look at a mutant mouse with vestibular defects, they are constantly circling. Their head is tossing. They have a real problem. They walk in a wobbly fashion. They can't swim. And this is all due to dysfunction of those hair cells that are in the vestibule and in the cochlea. And the cool thing about our gene therapy is that all of the treated TOMT mutant mice so far have had normal and rescued vestibular function. So we're rescuing vestibular function. They look like a normal wild type mouse now. And we're partially rescuing hearing function. So where are we now? In summary, we have efficient gene delivery to hair cells in the cochlea, but not 100%. And this was actually a pretty significant achievement because traditionally, historically, getting things into hair cells has been very, very difficult. I think we can get to 100%. We have partial hearing rescue that's variable, and I think the variability is actually due to the fact that we're not getting 100% delivery. So we have some ideas about how to address this. But once we can get to 100% delivery, I really feel pretty confident that we'll get much, much better hearing rescue across the frequency axis. We have vestibular rescue, and we have a better understanding of what TOMT does. And so we think it has a role in either assembly or trafficking of the MET channel. And we have a promising gene therapy strategy. So the next steps for us are, first, we have to get to a full hearing rescue. And what this means is we have to optimize things. That's what we do in the lab. We try to make things better. And one of those things is actually the vector itself. I'm not going to go into the details of this, but suffice it to say, we have a lot of ideas about how we can make the vector more efficient at getting into hair cells. The delivery conditions and timing are also things that we're adjusting. Also, we have to figure out what is the therapeutic window that we have. In other words, can we only give it at early stages of life? Can we give it at later stages of life? We'll start that in the tests in mice. Can we give it to adult mice and then get the same response that we would if we gave it to a younger mouse? We want to figure out the precise function of TOMT, and we want to take our gene therapy strategy and apply it to other deafness-linked genes. So TOMT mutations are relatively rare, but it's a really nice model to use to establish everything. Dr. Chi talked about some other more common forms of genetic hearing loss, like the connexins. And those are definitely on our future radar. Once we get the conditions worked out here, we feel like we can translate them to other genetic forms. So that's it. And I'd be happy to take any questions.
Thank you, Dr. Cunningham and Dr. Chi. We do have some questions already, so we're going to dive in. But for any of our audience members, please feel free to ask any questions through the Q&A function, and we'll get to as many of them as we can in the last remaining 25 minutes. So the first question that we have is for Dr. Chi. These genes that qualify for hearing loss, are they tested during the pregnancy process?
So currently they're tested. There's various different batteries of tests that can be checked for hearing loss, and we offer them at Children's Hospital of Pittsburgh. We test them after they're born and they have a diagnosed hearing loss. There are some considerations to do it during pregnancy, but as you can imagine, there are many ethical questions if it's done before, during the pregnancy instead of after the baby is born. But we offer in our clinic after the child is born and to check to see what the specific gene cause for hearing loss may be. And we do this with our genetics division at Children's Hospital of Pittsburgh. There are some associated costs with this, and typically we wait for the insurance approval for these tests to be completed.
And then the next question is there, and if so, what is the optimal age for a child to receive a cochlear implant?
So the basic premise is earlier the better. When cochlear implants first came available, they were first restricted only to adults. And then over time, they've been approved for children. At first, it was only for children who are 2 years old. Now they've been approved to 1 year old. And most recently, the FDA has approved to 9 months of age. The reason why is that the idea is that there are these nerve endings. And over time, the nerve endings may slowly retract if they're not stimulated. So we want these nerve endings to be stimulated as early as possible. We've at Children's implanted at as early as 5 months of age for various other reasons. If there's some medical conditions that make us do it more promptly, we have done them. But the FDA currently is approved for 9 months of age.
And does the effectiveness of gene therapy for hearing loss depend on whether the hearing loss is congenital?
I think that's an excellent question. And it totally depends on the particular genetic form of hearing loss. So some forms of genetic hearing loss, like Tom T, for instance, the hair cells in the cochlear structure is maintained for a long time, which means that you have cells to deliver the therapy back to for an extended period of time. Whereas other forms of hearing loss, the hair cells die, and if the hair cells die, then we have no essentially cells to deliver to. And so it totally depends on the particular genetic cause. And that could be a congenital form, or that could be a progressive genetic form. It just depends on at what stage and what type of mutation we are at when the therapy is given.
The next question is, do you have any sort of timeline? And I know this is always a very difficult question to answer, but do you have any sort of timeline as to when you hope to possibly see some of your research used in a real world situation?
As soon as possible. I do think we have an advantage, like I talked about before, because we have a mouse model that's very similar to the human model. So I believe there's a lot of translation there. I don't necessarily want to put a particular time on it, but the nice thing about being here is that we have excellent world-renowned clinicians that we can talk to make the research as translatable as possible. And so again, we're doing this in mice, and then as soon as we can make it work effectively in mice, then the next step will be considering clinical trials. So.
And this is a question maybe both of you could provide your input on this one, which is which do you think will be more effective for hearing loss, improving cochlear implants or fine-tuning gene therapy?
I'll take a first stab at this. I think in the short term, the medical technology is the easier, quicker answer. We can continue to improve cochlear implants. Some of the external processing of sounds can continue to improve. The long term, the futuristic answer, of course, would be that this research, this cutting edge research that Dr. Cunningham is doing will ultimately change. Who knows? Maybe in the future, there won't be any need for surgery for cochlear implants. And it will affect what I do, but for society, what a wonderful change that would be, where we may have treatments for hearing loss. So I think in the short term, it will continue to be technology, the media technology, the surgical technology, the medical technology that will continue to improve. But in the long term, it will be awesome that the work that Dr. Cunningham's lab is doing will change the face of hearing and how we treat hearing.
I'll just add to what he said. I completely agree with Dr. Chi. I think now and for the near future, the cochlear implant technology, improving the technology is critical. And in fact, there's people here, Michelle Insinelli is one at the Pittsburgh Hearing Research Center who's doing work on cochlear implants. That work is critical. And in fact, for many forms of deafness, if you don't reach the patient in time before the hair cells die, then either hair cell regeneration would be necessary or cochlear implants may be the only option. And so we need to do both things, develop gene therapies, but also make cochlear implants as good as we can make them. And so I think it's a multifaceted attack.
So Dr. Cunningham, you mentioned the role of hair cells there, and that kind of leads us into our next question is somebody's asking if you could kind of go into a little bit more depth in the role that hair cells play in hearing loss issues.
Yeah, great question. So hair cells, like I said earlier, you can call them mechanical sensors. So they actually move in response to sound waves in the inner ear, and that movement causes tension on those little hair-like projections that I was mentioning, the stereocilia. That tension actually opens up channels, and they're mechanically gated channels. And when those mechanically gated channels open, then ions like potassium flow into the cell, and that leads to neurotransmitter release that's sent to the brain. So the cells are essentially the gatekeeper. The hair cells are the gatekeeper between the sound wave and the neural signal. And many forms of hearing loss involve death or damage to hair cells. And one of the problems or one of the difficulties is that they don't regenerate once they're damaged. Other cells in your body sometimes will divide and reproduce and replicate themselves, but hair cells do not. And so there's a whole other body of research where researchers are trying to figure out a way to regenerate them. So you could think about many forms of hearing loss. In order to actually have a biological therapy work, you'd have to regenerate the hair cells first and then potentially deliver a gene therapy.
Dr. Chi, we have a question for you. It's how does cochlear implants in an infant deal with growth? Does the implant have to be replaced multiple times as the child gets older?
So I think that story is still to be told. The first generation of implants occurred in the 1990s. And we don't have a full life of a child who's now an adult who's had an implant. Having said that, there are various reasons where it might require to be replaced. It is an electrical device, and electrical devices can be prone to fail. And so it can be replaced for that reason. We don't expect that. It also can get infected whenever it's a device. So those are some of the reasons it has to be replaced. But it has not required replacement just because the infant has grown into an adult. We've had patients who are now adults who have their implants, and they are functioning great with it, as long as there's no defect in the device or some unusual infection that requires its replacement. We also are not in a situation where technologies change so much that the cochlear implant version 1.0 needs to be replaced with cochlear implant 2.0 because they're still doing fine with the internal device. The external component has been updated and continues to be updated because there's new technologies that allows a child, adult to use these cochlear implants. It incorporates Bluetooth, it incorporates various coding strategies that will allow them to hear better. But that does not require a surgical revision. So we will see. I'm hopeful that as long as the external technologies are able to be adapted to the previous generation of devices, and that there are no problems with the internal working of the device, that the infant can continue to wear it all throughout adulthood.
Well, thank you very much. And Dr. Cunningham, somebody's kind of putting you on the spot here, so we'll let you close up as the last question. They said, where do you want to take your research in the next year? So maybe if you have a goal in mind for the next year, what would it be for your lab?
Oh, but that's a great question. I want full hearing rescue in the TOMT mutants, and I think we can achieve it. And that means full 100% delivery to hair cells. And essentially, we have a number of ways that we're going to try to get there. We're trying them now. We've done more tests in mice, and we're going to continue doing tests until we get there. So that's one thing. I want to get there. I also want to really figure out what TOMT is doing. I mean, we have an idea that it's critical for the channel placement, but we don't know at what step of the protein processing step it plays a role. And so we're looking at TOMT along with other interacting proteins, some of which are linked to other deafness genes, to really figure out what it's doing. And the reason we're trying to understand that is so that we can have a broader understanding about how proteins are assembled and trafficked in hair cells in general. So figuring out what TOMT does, and also full hearing rescue in TOMT mutants, that's the next year.
Well, certainly seems like an ambitious goal, and I'm sure we will be paying attention to that, and I'm sure our constituents will be paying attention to that too, and looking for this progress. And Dr. Johnson, do we have some closing words from you on the topic for today?
Thank you, gentlemen, for putting on a really enlightening program. Millions of Americans lose their hearing with age, and almost all of that is attributed to damage to the hair cells. For instance, noise hurts your hair cells, and as intimated earlier by our two presenters, hair cells don't get better. So the hope here is that all of this science is going to help us learn potentially how to protect hair cells. For instance, are some people more susceptible than others? And is that susceptibility actually a form of hereditary hearing loss? And could we protect them? And then number two, of course, is this whole business about being able to restore hair cell function. I mean, that would be amazing. And I think you're going to see these things happen in the next decade. It's amazing.
So I also wanted to add that our department recently took place in the Mission of Mercy event here in Pittsburgh, providing hearing screenings and hearing aids to the community here in Pittsburgh. And one issue that arose was there were some children that had been seen who had hearing loss and didn't have hearing aids. And I think it's a common misconception that children, and Dr. Johnson can clarify if need be, children qualify for free hearing aids up to the age of, I believe, 17 or so. So if anybody is watching and has children in their lives who do have hearing loss, please don't look at it as a cost inhibitive procedure to help them get that help that they need. We encountered several children during that process who probably could have had hearing aids earlier and help with their hearing. So it's something to keep in mind. So I want to thank all of our presenters today, Dr. Johnson, Dr. Cunningham, Dr. Chi. Wonderful presentation. Thank you for joining us. And to all of our audience members, thank you for being here again as well. Please join us. We'll have another presentation in 2 weeks where we'll be going over integrative eye care with Dr. Deep Dollywall and Dr. Maureen Helena Herrera. So please join us for that. And again, if you have any questions, you can submit them to myself at craig@eyeandear.org, and we will look forward to seeing you at a future presentation. Everybody have a great day.